Hi, welcome to our show and our video cast, Taking Diabetes Head On, where we empower you. Today's show, it's our third show, believe it or not. Actually, we're going to be talking about Beyond the A1C. I'm Chris.
I'm Teresa.
And I'm Chuck. We ended the last show about talking about knowing your alphabet. The alphabet here indicative of A for A1C,
Absolutely.
B for blood pressure, C for cholesterol, D for diet, and E for exercise. Today, we are talking about A1C and beyond. Now, diabetes care is multifaceted and polymorphous, and indeed there are several layers to this. But to succeed, we need to know our numbers, get to goal, and treat to target. So we'll start off by just defining and understanding what A1C is. So Chris, can you give our audience a glimpse of this?
I guess a glimpse of it. The last show, you talked about the A1C actually being like a report card. And then we teased about Teresa and hiding her report card from her parents. But actually, when we got home, she was like, I don't quite like the report card thing. But I was like, Dr. Cannon used a very good analogy with the report card. It's really how well you're doing. It's a way to have positive feedback so that you know either to do better or you can just kind of hold stable. And I think that's the best way to describe it. And then we also talked about it being something such as the quality of life number with you and your diabetes. But really, I think it's the report card. I would say that's the best way.
So how do we describe to a patient or a person with diabetes what exactly is meant by this A1C?
The A1C is a glycosylated hemoglobin. It's a hemoglobin that has an affiliation for sugar. And that affiliation, basically, this A1C holds on to sugar, and the more or the higher your blood sugar is over the course of 3 months, there's a percentage of that we measure, and we call it the A1C. And that basically equates to an estimated glucose or your average glucose. And when we do that, it's more than just a finger stick. And I think Teresa has said that before. There's something more than that moment-to-moment finger stick. So sometimes if you want to lie to your healthcare provider, you can't, because the 3-month number really talks about it. And it's known by other names, Dr. Cannon, the other names?
Well, it's called several things, but A1C seems to have stuck. It's called glycosylated hemoglobin because, to take what you said, red blood cells that we all have, they contain hemoglobin. Hemoglobin carries a lot of things.
Absolutely.
And certain parts of it are attracted to sugar. So they get sugar coated when there is a higher percentage of blood sugar.
So this time it's okay to say sugar-coated, huh?
It is.
And we can sugar-coat stuff?
We can sugarcoat the stuff. So the higher your blood glucose is, the more sugar coating happens.
Absolutely.
And the 90 days or 3 months is simply a reflection of the life of the red blood cell, because its lifespan is about 3 months or 90 days. So when you check an A1C and get a result, it is the last 90 days integrated glucose burden.
So it doesn't lie, so to speak.
It doesn't lie, and it tells you exactly, it takes all your ups and downs and swings and bounces, puts them all together, and gives you a number of a composite.
It's kind of like our marriage, huh?
And you know what the thing is? Being diabetic, I don't want to sugarcoat anything. So let's get a good number and get that going.
So you didn't know you were between us for a reason, huh?
Uh-huh. Now I know why I'm in between.
So don't sugarcoat it.
Yes.
So Dr. Cannon, I have a surprise for you, because while Teresa was at work this weekend, I became an artist, and I have a hemoglobin A1C. What do you think?
That looks good. And what are these little white structures?
That's supposed to be sugar. So what we did, we figured, how many's on here, Teresa?
We said a hemoglobin of 10.
So there's probably more than 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, maybe 12. So let's say 12% on this hemoglobin A1C. What would that equate to on a blood sugar number?
This is a good question. The higher the blood sugar, the higher the A1C. Normal people who don't have diabetes have very low A1C levels. So this means you're dealing with the blood glucose averaging 300 to 350 plus.
Wow. That's a
So
big blood
this is a
sugar.
big burden.
Wow.
Wow.
So this is basically a crude hemoglobin A1C, but that's kind of what I
There
could
must
do.
be a reason why you've got them attached.
We have them attached because later when we're going to talk about this a little bit more. So when they actually have better control, we're going to remove some of these, and then that's going to be removing 1%, 2%, those kind of things. So that's something we're going to talk about in a little while.
That's very good. Now, this test practically every person with diabetes should be aware of. And how has this played out, Teresa, in the management of people with diabetes?
I think what's really nice about A1C is it gives you the average blood sugars. So, we test, but it only gives you that moment. And there's actually no bad number of A1C because all numbers are good, even when you test or your A1C, because it just tells you what you should be doing next. If your A1C is high or if your glucose is high, what steps to take to get it lower.
I like that analogy. There's nothing bad about it because
There's
really
no
what
bad
it's going to do,
numbers.
it's going to direct you. And just because somebody has a hemoglobin A1C of maybe 7, another with 8, another one with 9, that may be what they and their healthcare provider think is safe for them. Is that what sometimes happens?
Indeed, we will talk about this momentarily, but goals of A1C have to be absolutely customized. You cannot throw this number or goal across the board and say all people with diabetes must have this degree of A1C. So it's individual, it's tailored, and it's customized.
Can we go over what the A1C should be for somebody who's non-diabetic, pre-diabetic, and diabetic?
Well, basically, I think we kind of talked about it the last time, but I want our listeners to know now. An A1C of less than 5.6 is considered normal. That's a normal A1C, and when you start going higher than that, from 5.7 to 6.4, you're in a pre-diabetic stage, and when you're greater than 6.5, you're in the diabetic stage of hemoglobin A1C. But that's just kind of a moment in time. So sometimes we have the pre-diabetes, then we have diabetes, and sometimes we can get you back under, but you're still diabetic. Is that correct? So you're still on all the medicine. We can reduce it a little bit, but if we take your medicine completely away, then you go up to the diabetic number again. Is that?
That is very true because this A1C changes depending upon changes that happen to the blood glucose level.
Okay.
And people use this, as you pointed out, for screening diabetes, which is a very important thing in certain people. But more importantly, it becomes a benchmark or a surrogate marker for your control,
Absolutely.
for degree of control. And that is why, as we'll talk in a minute, there are goals that are defining where people with diabetes should be. But I've got a more relevant issue that patients always ask me. They keep saying, listen, why should I keep sticking my finger when I can come to the lab and get an A1C done every 3 months? Why should I bother checking my blood sugar? What do you think?
But I don't think that A1C by itself tells the ultimate picture, because sometimes you can have what appears to be a normal A1C or a lower A1C, but you've gotten there by having too many lows, and at other times you've had highs. And there's other people that have a little higher A1C, but they have more of a stable blood sugar. If you check their blood sugar moment to moment, or multiple times a day, you would see that they actually are more in control. So sometimes the A1C does kind of lie a little bit because they may not be in as good a control.
And it's not so much the fault of the A1C.
Right. But I think why people should test, it's a consequence of what you just did. If you decide to eat that big chocolate cake, you're going to see the consequences of that. If you decide, or if you want to do an activity, exercise, you should always know what your numbers are. People should test to know what's going on at that moment so they know where to guide from that point. If they're too low, too high, or perfect in the state of mind, what they want to do.
Absolutely, because all a high A1C tells you is that something is wrong.
Absolutely.
But not where.
It doesn't tell you the why behind the high.
The why behind the
I
high.
like that.
So
I like that.
it will only tell you I'm 12%, like this person. It doesn't tell you why this landed here.
Why is it there? And that reminds me, in our support group one time, and part of the reason that we've chosen the name Beyond the A1C today was someone asked me in our support group, why do I test? And back then it was stump the chump, kind of, because I was thinking so far ahead that I forgot the basic reason. And I finally had to say, like Teresa said just now, is it's choices and it's consequences. So the choice of what you put into your mouth, and the consequences what that little drop of blood says now. And that's something you can change now. And I think Teresa said that best of all. So it doesn't matter if you have type 1, type 2, you can change it now. And that's important.
But it's not only the food you put in your mouth, it's the activity you're doing too.
Your whole
Your
day-to-day
whole
living.
how much fluids you're drinking, what you're eating, how activity, all that. If you have an infection, because when people have infections, your sugars go up. So I think the day-to-day process of testing is a guideline to show you what's going on with your life.
Absolutely.
This is especially true in people who have big swings in their blood glucose level. And as Teresa knows and you have seen, we all see patients who are taking multiple shots of insulin, and they're swinging between 40 and 400. So when you get an A1C, the lows wash out the highs, and it looks deceptively nice looking.
And that's the truth.
And when patients say, but I have a great looking A1C, I tell them it's a little bit like having your head in the oven and your behind in the freezer and the middle looks warm. So this is not real. Now, having said that, are there some situations where this is not as reliable as it should?
There are. There's some individuals, especially African American people, in the first A1C that they get, sometimes there might be, I've heard that there sometimes can be a 0.5% change, and then eventually you'll know where the average is on there.
They become their own controls.
Absolutely. Then you'll also have people with certain hemoglobinopathies that have a problem. There's some supplementations that people take that can alter the A1C.
Alpha-lipoic acid.
Alpha-lipoic acid is one of them. Sometimes there's other things that can kind of get in there, and it just depends on the individuals. So usually if the physician knows that they have maybe a hemoglobin problem, or they have something like sickle cell, there's other issues that can happen, and that may not be a reliable test for those individuals.
When you say hemoglobin, you're also talking about anemia, correct?
Certain anemias, absolutely.
And that's important because when you're anemic, you are making more younger cells to compensate. And younger cells do not live as long as older cells. So the A1C in anemia can be changed. And when you're breaking down your cells for whatever reason, they don't live long enough, so you're not getting a 90-day average.
So you don't really get a true number.
Right. Kidney disease, we see the
Absolutely.
same thing. Very common situation is pregnancy. In pregnancy, the A1C content changes, and these do not reflect the real glucose.
And that's because the blood volume is actually 50% higher in pregnancy than before pregnancy.
Plus, they have a little more hemoglobin F than they have hemoglobin A, which is the A1C part. So it's a great test, and it really has become the benchmark of how we look at our management.
It really
In
is.
fact, a person's diabetes care is judged by A1C, although we all know there are factors beyond the A1C that contribute to that.
And that's something that I know that we're trying to point out today. And that's why it's important to do those blood glucose checks at least minimum 3 times a day at least.
It depends on
what medication you're
when
on.
medication you are, what your situation
And
is,
what your doctor
and what
suggests.
your healthcare provider has
Teresa, how many
recommended.
times a day do you test?
I test a lot.
And don't lie because your doctor's right
No,
here.
I know.
Well,
He
Teresa is a
knows.
model
He
patient,
knows I
so-
do. I test 4 to 10 times a day, even with my DSM.
And again, that's so crucial because that tells you moment to moment what you need to do.
Right.
So the consensus statements by many groups kind of give us some guidelines.
So I know the ADA says that you should the A1C goal that you should try to achieve is 7 or less, and the American Association of Clinical Endocrinologists actually say 6.5 or less is what they're trying to strive towards. But as we said, it's between you and your healthcare provider. And I was just at an American Association of Clinical Endocrinologists meeting just this past weekend, in which Margaret, your dietitian, spoke, and she did a marvelous job. And when we went, they actually, a lot of the folks there were talking about having those individualized goals, just like you said. And I was so impressed by that. I really was.
You know what I think we need to do is we talked about A1Cs, but I think we should go over what's our goals for our blood sugars when we test.
Absolutely.
I think that's important for
Because-
people who don't test, or when they test, they need to know what should they aim for. So I think fasting should be less than 100, but or less.
It's
if
customized,
It's
obviously.
customized, but the generalized.
It would be nice to have 100.
It would be nice. And then before meals,
Anywhere from 90 to 130. or 80 to 120, depending upon which church you
Absolutely.
go to.
Right.
You know? And post-meal,
Post-meal, they say less than 180
Yeah.
or 160.
So-
Depending upon.
your-
And some people, even I think AACE even strives to about 140, isn't that?
AAC is 140 to 160. The thing is, the American College of Endocrinologists, they have a little more stringent levels, whereas most of us who deal with lots of patients are comfortable with ADA guidelines. And the
Absolutely.
ADA guidelines, while their goal is a A1C of 7 or below, they also define postprandial under 180, 2 hours
Absolutely.
after you eat, and before meals around 90 to 130. There is comfort in that because you're not overstepping your boundaries, because the tighter you go, you enter a slippery slope of potential low blood sugars.
And that's something that we have to prevent. So remember, if you're listening out there, make sure you talk to your healthcare provider to ask exactly what their goal is for you. And that's what's important here.
And let's talk about when people exercise or drive. That's kind of important to know.
Very.
Right? So I think at least 100.
Easy.
Easy, right?
So,
What do
so
you think?
basically, I think what Teresa's saying is you need to before you get behind the wheel, check your blood sugar. If you think it's low, correct it. And sometimes if it's too high, you might have blurry vision. You may not make the right decisions.
Judgment
in your
impairment.
judgment. Yeah. So you need to make sure that you are really, you should set your own standards for what your blood sugar should be if you're getting behind a motor vehicle or heavy equipment or exercising. But I think 100 would be a nice goal for when you get behind the wheel.
And what about bedtime?
And the bedtime, generally, the concern is if you go to bed with a high glucose, you might wind up waking up with a high glucose, and then you have a domino effect. So under 140 milligrams, give or take. And these are averages. When we tell our patients to check numbers, we always would like them to tell us, what is my general average? It's not a one-day thing. It's a monthly average or a weekly average. And this gives them a clue where they are.
So sometimes when you look at the A1C, you also look at their meter too. So you want to download their meter and then also look at their A1C.
Absolutely.
So you can kind of see exactly where those highs and
And
lows
many of our meters today give us 15-day average, 14-day
Nice.
average,
Really,
30-month average. But it's more, averages are good, but an average is not so good when you're swinging between 40 and 400.
And that's where the CGM, because I know Teresa has the CGM. So sometimes if you have the CGM, make sure your doctor's looking at your CGM numbers as well.
And these days, when we say beyond the A1C, yes, this is a good number. It's a very good first cut. But more important are blood glucose measurements. And equally important is time spent without going too high or too low.
Absolutely.
And that, a lot of it has to depend upon what medication you're taking, what type of person with diabetes you are.
True.
And but this is the finale for all this is, why is the A1C goal set here? What are we trying to accomplish by persistently getting good-looking A1C levels?
I think when you're doing that, you're for each 1% that you decrease. There's been studies in UK PDS. You have the DCCT trials. We understand that you can reduce the risk for retinopathy, for heart disease, kidney disease,
complications.
neuropathy, all your complications. You can drop those. Each percentage that goes down, you have less and less chance. Sometimes I think it was as much as 40% reduction in some of those just by 1 or 2 percentage points. That's huge.
But I think we have to remember, like we said, A1Cs was recommended from your doctor to know, because you don't want a low A1Cs if you're constantly going low.
Very
That
true.
would cause major issues.
Other
just
issues,
other
which
issues.
are worse.
Right, worse. And in kids, being teenagers, they don't want their A1Cs low either because they need that extra sugars. So I think you need talk to your healthcare provider to say, hey, what should my A1C be?
You
at?
hit the nail right on the head, because too much of a good thing and how low is low,
Right.
lower is not necessarily better.
Exactly.
And when you get to A1Cs going towards 6, especially not only children and adolescents, older folks may tend to have more tendency to pass out, fall,
You could even have a heart attack.
because when your blood glucose declines, you're going to release all that adrenaline, all that catecholamines, and you're going to constrict your vessels. So that's why customization is important.
And I want our listeners to understand this is so important, because when you have diabetes, you have 2 to 4 times the risk factors for heart attack and stroke. So you definitely need to make sure that you don't have too many lows, because those lows could cause a heart attack, and that's what we don't want.
Remember what grandma used to say, too much of a good thing can be bad for you.
That's
You
true.
know, so on that note, I think it's very important that you speak to your healthcare provider to talk about what is your goal, where should I be, and how should I improve what I'm doing.
Absolutely.
And remember, A1C just tells you that you're high. It doesn't give you the why behind the high.
So I have a question for you on this A1C. So let's say that I'm type 2 and you give me some metformin. What would I expect here? Maybe 1 or 2 of
One
these
or
balls?
two. You get 1 or 2.
So I get 1 or 2 come off. So there's a reduction in 2%.
You can't come down to 10 now.
So
from
I'm
12.
now 10. Now I do
Exercise.
Lifestyle modification.
It's a big,
Exercise.
Maybe 1 or 2 and exercise.
easy.
Reduce my carbohydrates.
Right.
Take some insulin, maybe long-acting insulin.
Or another medication,
Or another
perhaps.
medication. What, 2 or 3 maybe here?
And now you're down to 7.
Wow. So with this being said, this is the why
Behind the
behind
high.
the high.
Yes, indeed.
And this is why we treat as we treat, so that we can eventually find out what's going on through your day-to-day blood sugar and your A1C. And this is really beyond the A1C, I
And
think.
that's a very clever representation.
Yeah, well, you know what? Teresa was mad because I think I got the red paint all over the house, but I think we did okay, though, for my first art project. So
Yes,
it's a
yes.
therapy on the
And you
weekend.
painted it red because it's hemoglobin.
Absolutely.
Color of hemoglobin is
Absolutely
Hemoglobin.
red. Yep, that's what we have. So I think I think we hit the nail on the head today that the A1C, your blood sugar, is so very important.
good. And that brings us to the end of today's show. And thank you very much for watching.
I'm Chris.
I'm Teresa.
I'm Chuck. And we are taking diabetes head on.
Absolutely. See you next week.
Please like or comment or subscribe. We love hearing from all of you. So please feel free to email us. And don't forget to visit our Instagram, Twitter, Facebook, as well as our website.
Thank you.
Thank you.